Night, everybody. Just waiting for a few more people to come into the room. Going to have our talk tonight on C-section. Hope everybody doing well. Just waiting for the room to populate a little bit. Run a little late. And everybody was calling me. I had these people. Hold on. Just inviting everybody. Jody. Andy. Alright, I sent the invitation, guys. You see it? Night.
Hi.
Just making sure everybody, sending it to everybody 1 second. Kevin, I just sent it. Jody, I just sent it. What you doing, Monday? You good?
I'm good.
Kevin, you guys got it? Dr. Jarrett is unable to join. Should I
Oh,
test
not
this?
again. Not
Yeah.
again.
Dr. Henry is unable to join.
What is happening?
You guys send me a request. Technical difficulties. Send it again. Kevin, send a request. Jody, send a request. All right, let me do it one at a time. I just sent to Kevin. You answer and see what happened. And I only have one phone, you know. Doc is coming. Loriski said Doc is coming. All right. Jody, what's happening? Listen to Jody. Oh, God. Same problem again on Monday.
Yeah, same thing as the last time.
I
But we
don't
got
hear.
it started the last time, though.
Yeah, they work. I think Kevin Henry is unable to join. Oh, hold on, I have something here. Accept Kevin a while ago.
All right, we're getting somewhere.
Hey man, oh God, what's good? What's good?
What's up?
All right, Jody now.
Jody now.
Jody, send a request, cause obviously this thing not working when I send it. Oh, I said Jody online now.
All right.
Vibes.
We're here.
Finally. It feels like it's been a year.
Yeah, I'm sure it almost is.
Yeah. Sorry.
We need to do better for the people.
Yeah, we need to
Life.
we should try you know you can go private, you know. Should I try a dry run first?
Oh, you can
Or
do
you can do
that
that?
next time.
Yeah man. You can do a well, I don't know if you can do a private run with 4 people, but you can do a private run by yourself.
Okay.
Oh.
Jody, we lost
Jody
you.
there?
Give me 1 second, guys.
Sure.
All right.
What you guys doing today?
Tired, but good.
Today wasn't too bad. How your day go, Monday?
It was good. Can't complain.
Kevin, how was it?
Yeah, it was a fairly productive day.
Yeah, I
You
agree.
give thanks when you get through some good things during the day. You know?
Yeah.
Okay. I wish I could say mine was fairly productive too. I joke, it was fairly productive. It wasn't bad. It wasn't bad. It was productive. We got everything that we had to get through today.
Exactly.
We got everything that we're supposed to get through today.
Yeah.
Dr. Jarrett have flow. I don't know. I did yourself. Where you have Monday?
Digital.
And where you have?
I have flow.
Flow, but yeah,
Somebody literally said you have to know, Jody.
Yes, I did.
my flow Wi-Fi don't shake, you know. Right?
Really? All
Oh
right,
yeah?
all right. Big up flow, big up digital.
Exactly.
I don't
My
know.
digital,
Kevin
my
must
digital
have
solid.
shares.
Yeah, man. Thing good.
The flow
Kevin
of
have
mine,
shares or a tower.
the flow of mine, but the whole the flow of mine, but the whole shaky,
Shaky.
Shake it bad, I
very
don't know.
shaky. Jody, we're waiting for your presence now.
I'm here. I'm here now.
Oh,
Yes,
all right.
Oh, all
okay.
right.
It's a little more, but I trying to, young like you get. I just run off the road and come in here.
There you go.
Okay. All
So
right. So a few months ago, I made a post. I saw a post on Instagram, and I said it would be a very interesting topic. This is months ago. This is probably like I was looking in the group. This is when I posted it. Probably
Yeah,
like
that was a couple
Long
months.
time, man. Long
yeah,
time.
yeah, it
man,
was
like
only go
3 or
while
4
back. So
months. And I shared it, and I said this would be a very interesting talk to have. It's something that every pregnant woman asks, no matter what. It's a topic that is very topical slash controversial slash it just needs to be spoken about. And I realized that we haven't touched on it, we've touched on everything else but that. And I think that tonight is the night that we do it. So the post that I saw in 1970, 1 out of 20 women had a C-section. Now it's 1 out of 3. Did babies stop knowing how to birth themselves? Is the medical system unnecessarily rupturing uteruses for financial gain? What a tough statement. What a tough statement. What a tough statement.
No, rupture,
Yeah.
that's so
Jody,
graphic.
Rough.
Jody, we need you back in. Yeah. Rupturing for financial gain. What you guys think about that? Oh, Jody just jumped back in. Oh, who is Robin? Gosh. Jody, send a request again. Some random person requested to come in, and I accepted it by accident.
Somebody wants to talk about C-section.
Well, one comment, man. Well,
Yeah,
one
man,
comment.
some random person jumped in. Jody, send your request again, please. We're just about to start getting spicy. Oh,
Where that thing that you're quoting a while ago, right? It was
yeah.
an article, or what was it?
It was a post
Yeah.
on one of these pro vaginal delivery website, Instagram pages.
Okay.
You know these pages? I
It
don't
was
remember
like
which
a
one it
medical
was.
professional posting.
It probably is a medical professional, but you have these pages. I follow all of them. You have some of these pages that are always pro vaginal delivery. I don't remember the name of the page. And there's one of these pages, and I got it and I saw it would be really interesting to talk about. But it wasn't I wouldn't say it was a medical page per se.
Mm-hmm.
The information was accurate. The statement is pretty accurate, right? So just to inform everybody, so the WHO, that's the World Health Organization, they recommend that the C-section rate should be between 10 and 15%. When I did my study many years ago, like in 2014 at UA, the rate was around 35%. So that's the rate at which C-sections are done, guys. Right? So the WHO recommends 10 to 15%. At UA, it's 35, and the average rate in America right now is about 50 to 55%. So my question to my fellow colleagues here, do we agree with this statement about the 1 in 20 and now 1 in 3? Jody, shake him on.
Yeah.
Flow tower. Well, I strongly disagree. Right? Strongly disagree. Meaning that there are, and I'm sure that we'll get into it, there are a lot of different reasons now why, C-sections are performed versus why they probably weren't being performed before. There are new things that we have learned, as the profession develops. And we'd also have to compare it to what were the outcomes of those babies that were being born, for both mother and baby back in the day when the C-section rate was much lower, and the reasons that we're doing the C-sections now. So I definitely wouldn't agree that the majority of C-sections now are being done just for financial gain or for, insurance purposes and to push that agenda. The majority of C-sections now are done with the best interest of both the mother and the baby, first and foremost.
True.
Mandy, what do you have to say about the statement?
All right, so let me be devil's advocate. Yes, I agree, especially among us. I can say we do it in the best interest of the mother and baby. And I don't think the majority of doctors would be doing it for financial gain at all. But I think there is another aspect, which is also fear. I think sometimes we have patients, maybe baby and mother, maybe difficulties that we could possibly see them through, but the fear of not having a safe delivery, the fear of litigation, I think these things do factor into our decision to do C-sections versus going through a vaginal delivery.
I'd agree with Mandy. I would definitely agree with that. I think what it is that in 2022, with all the advances and stuff, patients tend to not be as forgiving for us to give them a chance, right? Because they're like, they're why the end of the at the end of the day, their thing is gonna be why we never intervene. Why was there no intervention if you thought it was that the baby wouldn't have made it? And I think also fear of one litigation, two, just not wanting a bad outcome. Like, who wants to bring your patient to that point and then something just go completely awry? That's not something that you want to happen. So you're definitely going to be more aware, observing more, and definitely quicker to intervene rather than to give the chance.
I think sometimes we have a lower threshold for C-section just based on those reasons.
Definitely. You definitely don't want to have a poor outcome. So if at any point in time something looks like it's not good either way, I think most of us would definitely go with intervening rather than to see what happens. And I don't think any patient would fault us for that.
True.
I agree with all you guys are saying. A wise doctor once told me obstetrics is art, craft, and science. The science is what we learn in medical school, in residency, when to intervene, when is the right way, what is the right thing to do, and the evidence is there to back it up. And the art and craft is basically our experience as we go along. And you have to meticulously balance everything in order to come out on top. And at the end of the day, what we really, really want is a healthy mother and a healthy baby. So whatever means
by
necessary,
whatever means necessary.
Whatever means necessary, And what patients or people generally need to remember is that this is what we have been doing for a living. We have delivered thousands of babies. We have seen the good, the bad, and the ugly. Definitely. And sometimes we have to kind of lean on our experience, which may be a little bit more than the patient's experience, because we have delivered thousands of babies. So we have to kind of balance it, art, craft, and science, and ensure at the end we have a healthy baby and a healthy mother. So I guess we can all agree that we don't agree with the statement, and I guess we'll go into it as we go along. So what is very important, I always like, and I'm sure you guys do it, from the very first visit I do with the patient, that first pregnancy visit is always the longest one, because we go through that entire pregnancy And then, delivery is such a big topic. What about you guys? How is that?
Yeah, for sure. The thing is when you're discussing delivery with a patient, right? You have to break it down to them in terms of pretty much a summary of all of the possibilities, right? So how I like to explain it to my patients, and these are patients who, normal low risk pregnancies without any indication or reason for a C-section up front, is to say, look, in terms of delivery, most times babies are delivered vaginally, right? Most times everything will go fine. You'll have no problems. You'll be allowed to deliver through the vagina as is normal, right? So a C-section is really done in the event that, one, we pick up something from before that we know from before you even go into labor that you're gonna need a C-section, or two, if there is any emergency or urgent thing that happened during your labor process or delivery process, either to you or the baby, that's going to require a C-section. So always be prepared for the possibility of a C-section occurring. I think that's important to explain to the patients, because I have had patients before who their thinking or their mindset about pregnancy and their approach to pregnancy was that I'm going to deliver this baby vaginally no matter what, right? C-section don't come into the equation. Surgery don't come into the equation. And that may be for different reasons. They may have had their own, birth plan or their own wants for the delivery. Some persons are just scared of surgery. Some persons have had, relatives, friends, whatever, with past experiences that were negative. And so everybody has a different outlook on C-section. Some people believe in it. Some people don't like that idea. And so it's important to explain to them that it is a real possibility in terms of one of the ways that they could be delivered, but also to comfort them, to know that it would be in the best interest for them and the baby,
Yeah, definitely. That's definitely something in detail with my patients. So we'll go through each trimester, what to expect, how often we're going to do visits, stuff to avoid, stuff like that. But definitely the delivery process, especially for a first-time mommy, especially for they have no idea what to expect. Always explain the whole process to them. Always explain, the best thing for you usually is the vaginal delivery, but always going with an open mind. Cases and anything looks like it's not going as planned, be prepared to do the surgery. And you have all of 36 weeks or whatever weeks to think about that. Wrap your mind around that thought, because I can guarantee that if you're opposed to it and opposed to intervention, and I see the need for the baby to be taken out immediately, and you're opposed to it, then I'm not your obstetrician. Because I cannot sleep at night knowing I allowed something negative to happen because you were opposed to it. Because at the end of the day, you're going to blame me, even though it was your decision. So I always tell my patients, you have to come into this with an open mind. Most of my patients deliver vaginally, but there are some where I do not drop the ball. I do not wait to see if something is going to happen. If it looks like it's going all right, I'm going to take that baby.
Mandy? Oh, yeah. Okay. That's your approach as well at the beginning?
Yeah, but I also find a lot of my patients bring it up. I find a lot of the times the patients come, first of all, say, Doc, I don't want to have a section. I find at least 75% of my patients would mention that at some point. And then I would have to go into, well, that's not our aim. However, it may become necessary. And then we discuss all the different points there.
I think we all agree that we're doing. I mean, we're all trained the same place. And
I think so, yeah.
And basically, the standard of care is essentially the same. That first consultation, as I said, I always tell patients, look, as Kevin mentioned, 85% of deliveries, nobody is needed. OB is there for 15% when things go wrong. And things can go wrong in labor, before labor, after labor. So we have to intervene appropriately. And, those patients I find, man, they're the ones who come in with a mentality like, look,
They don't want.
it's vagina alone. Those
Those
are
are the ones that end up.
difficult ones. And at the end,
Yep.
like, I'll give an example. I had a patient who worked up in a bank, and I've given her all this information, and she was saying, "Oh, doc, I did a vaginal delivery." And I said to her, "People trust you with their money, right? So what I want you to do is to trust me with your pregnancy, right? You understand? I mean, we're aiming for a vaginal delivery, but I tell all patients this. Unfortunately, I don't have the gift of prophecy. I have the gift of experience, and I will do whatever it takes to get you and your baby to the end of the road. That is all that matters at this point in time. And then, as the pregnancy progresses, we just take it day by day, and but those patients who are hellbound, which is a lot of them, we just have to talk to them and communicate with them. Every visit we have, just let them know, like, look, this is a possibility. I hope just try to bring it up. Indirectly. All right, so let's just jump right into it now. So, Jody, what is a C-section layman terms? As layman as possible.
As layman as possible.
Yeah.
All right, so C-section is a way to deliver your baby through your tummy. Surgery, cut open the tummy, take out the baby, close it back up. That's it.
Okay, so how much layers we have to go through? How long does it take?
Also, no, it's technical, right?
Yeah,
Yeah,
that's
No longer layman.
a above layman.
For a cesarean section, it's also referred to as an abdominal delivery. So basically, we go through skin, the subcutaneous fascia, the fatty layer, what we call the fatty layer. It's another layer of fascia. We open the rectus abdominis, which is your ab muscles, lay down. And then we go through what we call the peritoneum, which is a thin covering over the abdominal cavity. And then we retract the bowel, retract the bladder, and then we basically dissect the bladder off, because the bladder is directly related to the uterus at the front, which is one of the things that the things that consent for any possible damage. We deflect the bladder down, and then we cut through the layers of the uterus, get the baby out, suction, nose, clamp, cord, and the baby to the pediatrician. And then we close all the layers that we cut through. Make sure that there's no...
I call the placenta.
Placenta, we close back. And then, we basically close back every layer that we cut through. And that's pretty much it.
Yep. And we can normally do it under spinal anesthesia.
Or general
anesthesia.
We prefer spinal.
I prefer spinal.
Yeah, we do. I mean, what I tell my patients, because a lot of patients do what they're like, they don't want to be awake, they don't want to. I was like, you don't want to miss. If you have an option, you don't want to miss those first moments when the baby comes out.
Definitely.
Get to hold the baby, that's all a part of the whole process. So
get your pictures.
Yeah, you get your pictures. You don't want to miss that part. So even though they're maybe afraid of surgery and they may not want, after you discuss that part with them, they kind of come around and say, okay, all right, I'll go with the spinal. But and it's also less complications for the baby. Sometimes general anesthesia can actually cross the placenta and depress the baby's breathing and stuff like that.
All right, so this is a big topic, and I know everybody here is going to get a piece of it. So I start with Dr. Henry. Why that? So why we have to do the C-section? Tell me why we have to do the C-section, yo. Reach
Uh,
40 weeks now, and you're telling me something in a C-section. I'm kind of disrespecting you, on that. Big man, quick.
um, is that, it's it, it's a tricky one, right? Because so usually when the time for the C-section comes, meaning if there's an emergency and we need to do a C-section, I actually find that sometimes it's easier to explain it to the patient at that point because they can understand, and sometimes you can even show them what's happening, as opposed to when a patient comes in office and they just want, so doc, so what could I make me get a C-section? I'm like, there's so many things that could cause you to get a C-section, right? So we usually divide it up into causes, what we call maternal causes, which are things that so something with mommy, fetal causes, which are something with baby, and then other things, right? So sometimes, so like for maternal causes, so for women who in some cases have had a previous surgery on their uterus, so for patients who have had surgery to take out fibroids, for patients who have had certain types of C-sections before, that is a reason. For patients who, the reason that we did a C-section before is what we call a recurrent indication, meaning that we know that this is something that will require to have a C-section and it's not going to change. So sometimes one of the common things is, for example, if your pelvis is too small, in layman's terms. So your pelvis is too small and we don't think that baby would be able to pass through the pelvis safely. The size of your pelvis is not going to change, right? So if it was small for the first pregnancy, it's likely that it's going to be small for all of the pregnancies going forward. So if it is that arguable, but if it is that it's more than one pregnancy, so meaning if it's twins or triplets, that kind of thing. Sometimes if you have other conditions, other medical conditions, such as say you have diabetes, hypertension, and we have brought it to the point now where we're going to try to deliver you vaginally and we try to induce labor, and that induction has not worked or has failed after several attempts, then we'd move on to the C-section, right? Mm-hmm. In terms of for the baby, if the baby is not in the right position, so if the baby is like in breech position, which is bottom way down instead of headway, or the baby is sideways or slantways, the baby can't come out like that. If it is that we pick up at any point that the baby is in distress and we think that it's going to be too much pressure, it's going to be too stressful for the baby to attempt to come through with all of those contractions. If it is that the baby is too big, we call macrosomia. So we think that there will be potential damage when the baby is coming through the pelvis, or that the baby can get stuck. So many reasons.
Placental causes.
Right? Placental causes. So if
the
placenta is blocking where the baby should come through. And then, of course, during labor, the labor process itself, you can have emergencies that will arise. So you may be laboring fine, and then all of a sudden it starts to slow down. You're not dilating as quickly as you should, meaning the cervix isn't opening up, or the labor is not progressing as at the rate that it should. And we've tried everything to try and let you dilate, and you're not. That's the reason for C-section. Usually during your labor process, we're monitoring both you and the baby. So if when we assess, we're seeing that the baby seems to be in distress, the heart rate is too fast, the heart rate is dropping, that's another indication. If you start to have, very, very heavy bleeding, that suggests that probably the placenta, which is the afterbirth, has now separated or pulled off the wall of the uterus, which would cut off the blood supply to the baby. That's another indication. So
the cord
prolapse, yes. So sometimes when the headwater is ruptured, the umbilical cord can actually drop through the cervix, and that is a disaster. Right? So there are a lot of different obstetric emergencies or indications that would be exhaustive to try and go through every
single one.
possible reason. So that's what I explain to patients as well, that there are many things that can happen that can cause a C-section. Most of the time, they don't happen, but there's a possibility that it can happen. And it is my job or our job as obstetricians to look out for those things and pick them up early so that we can intervene at the appropriate time when necessary.
And just to add, again, I'm going to play devil's advocate here. A lot of times you may not have a straightforward maternal, fetal, or other indication. You know, sometimes you may have, for example, a patient who has a bad obstetric history. She has had a history of numerous miscarriages. She has a rescue cerclagen, a cervical cerclagen. She has high blood pressure. She has diabetes. These are the kind of patients that
previous stillbirth, when they went to
stillbirth, yeah.
You want to counsel these patients and let them know and say, look, we'll have our track record is not so good right now, and we want a controlled environment for this child to be born. Not saying a vaginal delivery is not controlled, right? But usually vaginal deliveries are sporadic, and we as just obstetricians have to wait on nature to follow through. Whereas in a abdominal delivery, a planned delivery, we are kind of in charge of what is happening.
Control,
so we have a greater manipulation of the whole scenario.
It's more predictable.
It's more predictable. Thank you so much, Mandy, for that term. It's more predictable. So that scenario is not a hard and fast. So that is more like obstetrical experience, you know, what I like to call an anecdotal experience, or anecdotal indication.
Never discredit that gut, you see?
Never
discredit that gut.
I used to tell Kevin that when he just started. That gut feeling, like the one you feel right
right here. I put it to you, I don't even think this is, well, I mean, definitely for us as obstetricians, but you'll ask any obstetrician, if a gut feeling tells you, listen, get that baby out and you deliver, 9 times out of 10 when you're going to find a reason that this baby had to be delivered.
On the neck.
You know? You're going to find a reason, for sure.
And I wouldn't say obstetrics, I would say medicine on a whole. That gut feeling, I mean, throughout my entire medical career, even before I started obstetrics and gynecology, I interned in the emergency room. That gut feeling, that first thing that comes to your head, I say, all right, you don't question it, you don't second guess it. Don't go right, we're just doing it. And you have to put your foot down, you know, because the patients will say, but why? You know, you have to put your foot down and say, look, this don't feel right. You know, this don't feel right. I don't like how this feel, and I always tell patients, just everybody, listen to what your doctor says, you know? Listen to what your doctor says. Listen to what your doctor says. Just like we have to listen to the patient, listen to what your doctor says, you know? And again, as we alluded to in the first time when Jody was talking, at the end of the day, we just want everything to be fine, you know? If anything happens to that baby, no matter what, if you did that pregnancy by the book and the outcome is bad, it's always the doctor's fault, no matter what.
In the eyes of the patient.
In the eyes of the patient.
In the eyes of the patient.
And
done public by the time the patient.
Yeah, man, it's always the doctor. I mean, you could have that pregnancy down to a T, and unfortunately, the outcome is not what we want it to be, you know. But it's that they're going to scrutinize that case and find out what wasn't wrong. But as I said, always do what you're supposed to do. I don't want to go down that road. All of us do what we're supposed to do. And just trust your OBs, no matter where you are. I get a lot of second opinions all the time, locally and abroad. That's what I think about this. You know my answer is? I trust your doctor. I think you should as well.
And it's important. No, but it's also important, especially with obstetrics, right? That you have a comfortable and good relationship with whoever your OB is for that pregnancy. It should always be for that 9-month duration. You are able to have open discussion, questions. You can talk about anything. Doctor can answer. Doctor is listening to the patient. We'll go through all of the different options, plan the birth, etc. Because you don't want it to be that when it is that you reach the the labor process, that is when you're second guessing your doctor. That is when you're wondering, is this person making the right decision in the best interest of me and my baby? And it's also not when you as the doctor want to feel uncomfortable with the patient that you're trying to do something in their best interest and they are, you know, having doubts or second guessing. And that is not to say that the patient will ultimately still make the decision for her and her body, right? But it shouldn't be an antagonistic relationship, you know? So, yeah.
Very important. Just have that good open two-way communication with your doctor. It's very, very important. Not just obstetrics, but most importantly in obstetrics, you know?
Yeah.
And I find, and I'm sure you guys agree, most of your pregnant patients, you develop a bond with them. You develop a different kind of camaraderie. It's no longer, it's rarely patient-doctor relationship. It's a cohesive unit, and it's not you alone going through the pregnancy, but it's us. It's a team. We're going through this together, you know. And I find the majority of my pregnant patients, we're very good friends right now. You know, I'm godfathers for some. You know, it's a very
because the thing with that is that with your routine patients that just come into office for gynae purposes, a lot of times you probably see them once, twice, max maybe 3 times in a year, right? With a pregnant mother, you're seeing her, if she started to do it from the beginning, you're probably seeing her 10 times, 11 times,
10,
you know?
10 to 12
So
times.
at least 10.
you're regularly seeing this person and building that rapport and that relationship. So that bond is very important, you know?
And we get invited to the baby showers.
The baby showers.
To the gender reveal,
everything.
All these things, you feel like, wow, when did I drop in? But, you know, everybody, this is my doctor, you know, you feel, you know, so it's a very good camaraderie, and it's very important. That trust on both sides is very, very, very important. And I can't stress that enough. Patients, you have to trust your doctor or trust your team. You know, just trust your doctor, trust your team. Just believe they've done this. Know they've done this thousands of times. And we just want the best for you and the baby. If it's a vaginal delivery, that's perfect. If it has to be an emergency C-section, that's still perfect. You know, all that matters is you and your little one. All right. Okay, I have this here. The next one now is, all right, Mandy. Maternal request for C-section. Can I choose to have a C-section?
So you can choose to have a C-section. So it's actually, there are many different schools of thought on this. There's actually a big topic. It's called CDMR, so cesarean delivery by maternal request. To be honest, a lot of the boards discourage it because of all the complications that can be associated with a C-section. However, very early in our medical career, back in med school, we were taught about patient autonomy, which basically means having a competent adult make an informed decision on their medical care. So for me, once my patient is informed of all the risks, all the complications, all the alternative methods they can use, then I am comfortable with them choosing a cesarean delivery once they have all the facts and they do that.
I agree wholeheartedly.
I agree.
You know, that's only happened to me 2 times.
So what has actually happened?
Then only 2 of your patients have requested.
Only 2 of
No, my patient request regular.
My patients, they must do like
2 patients.
The amount of requests I get,
Came in,
literally,
doc, I want a C-section.
them come and doc, I have no interest in pushing.
I
have no interest in
pushing.
I'm not interested in feeling that pain. I don't want my anatomy to be distorted after, right? I actually had a patient once. She went the whole way, right? Reached 40 weeks. Reached like 40 weeks and 5 days. So she was post dates. And I said, all right, well, you know, she was set for vaginal. I said, all right, we're going to admit you and we're just going to induce labor and continue. She called me and she said, boy, doc, you know, I talked to my family about this induction thing, you know, and nobody in my family believe in induction, you know. So we're going to do a section. So the whole time, you know, she was ready for section. She was ready for vaginal delivery. And I said, no. You know, but the interesting thing is that when you actually look at when you look at the studies now, right, or the data now, the data is showing that for a simple, uncomplicated cesarean section, the risks that are involved in terms of morbidity or the issues with mommy are almost equivalent now to a vaginal delivery, right? Yes, there are different things that can happen with C-section versus vaginal, but if we're talking about it from just a risk perspective, they're pretty much almost the same now, right? For uncomplicated,
especially in experience hands.
exactly.
True.
It depends on if you're comparing it to which countries you're comparing it to as well. So, for example, the highest rate of C-section for maternal request is Brazil, where they are very big on maintaining the body figure and the shape and that type of thing. So that is where it has the highest. I think it's up to like either 50 or 60%. You just come tell your doctor that you want a C-section. That's it, right? But if the risks are no different than vaginal, then why not? You know. The only thing that we'd have to explain to patients is, while that may be our opinion as gynecologists in a private capacity, that does not necessarily hold true in the public system, right? So you can't just go to a public hospital and say, I would like a C-section just because I want a C-section at a public hospital. That it's not gonna happen out.
Yeah, and the main reason for that is resources. You know, we're in a third world country. We don't have access to resources. Both myself, you, and Dr. Jarrett work in the public sector, and we see the amount of patients that we see daily in the clinic. And imagine if all those patients were requesting C-sections. That would
Definitely
be
not.
insane, you know.
Yeah.
So
Definitely.
it has to. You have to look at the economy and the society, and definitely in a third world country in Jamaica where resources are low, we cannot be offering cesarean sections to everybody. You know, it can work in the private sector when patients are paying the hospital to purchase these resources, but in a resource poor country, it's not the ideal way to go. You know, because I'm sure you guys get requests from the patients in the clinic all the time.
Yeah.
Oh, really?
Yeah, man. I get
man. All the time.
The patients in the clinic want C-sections. They're no different. They want C-sections too.
I want to tell you that a lot of times, you know, they know, like, they've heard, like, other people who probably ended up with emergency sections and stuff like that. They've heard like the complete, like how they end up with the section, and they come and tell you, "Oh, doctor, having headache and blurred," like they have like signs of I kid you not. And I'm like, with a normal blood pressure,
and us who have been on the labor wards know that you get once that pain starts, you know, right? And it's like, take this baby out. I want a C-section. Let's go.
Mid delivery, mid attempting to push, they're just stop.
Yeah.
Like, no, cut me.
Take that.
Like, you can't reach this far. I'm looking at the baby's head right now. You can't do this. Like, it's gonna take too long to convert to that.
Back to the point that you mentioned, Jody. The patients will I'm not saying everybody does, and I'm not accusing anybody of doing this, but I've had situations before when patients will say the baby is not moving, you know, and then when they get into the history, like one will say, boy, that, you know, I just kind of want the baby to come right now and I can't wait. So I tell her that. When I tell her, when I told her I have to admit her right now, he said the baby not moving, another pregnancy, we have to the test to see how we're going to deliver a baby. Oh, no, doc, I don't mean all of that.
I feel it now.
I just want the baby to come sooner than later. I didn't want to get admitted. I could have come 2 days later for the C-section.
Yeah, man.
You know, so it's multifaceted.
Yeah, definitely.
All right. Next question. I want to get through these before we go to the question and answers. Okay. What happens after C-section recovery? That is you, Kevin.
After C-section.
Aftercare.
Yeah. So that is important, because I think from my experience with patients, who have had C-sections before, and even some of my close friends who have gone through C-section. A common complaint is that everybody tells you everything about the pregnancy and, you know, up to delivery, but nobody prepares you for what happens after that baby comes out, you know, especially when you're delivered by C-section, in terms of how you manage, you know, with the baby, along with,
Baby
you know,
plus.
tummy and, you know, having a wound there, and that recovery from surgery itself, in addition to adjusting to motherhood, you know. So in the immediate stage, or immediately after surgery, what usually happens is, after you've recovered or woken up, or, you know, or come out of the anesthetic, you get transferred back to your room, and usually what happens is you tend to be in hospital for about 2 to 3 days after you deliver, once everything is fine and everything goes well, right? During that time, what we're doing is we're checking to make sure that you are walking or moving up and down by the time you leave. So by the second or third day when we're going to discharge you, we want you to be up and down, right? Comfortably. We want you to be using the bathroom on your own comfortably. We want you to be eating and drinking comfortably, because these things suggest to us that you're able to move with, you know, relative comfort. And the fact that you're eating and drinking and using the bathroom without any issues suggests that your bowel has started to work like normal again, right? Now, it is important to remember that at the end of the day, you've just done a surgery, right? Which Dr. Jarrett explained. We had to go through a lot of different layers to go through to get into the abdomen, to cut the uterus and take the baby out. So a lot of healing is going to be going on after you have delivered by C-section. So because a lot of healing is going on, it comes with a lot of things. So there's responsibility in terms of taking medication, 1 for pain, 2 for antibiotics to prevent or cut down the chance of getting any infection. Your wound care is going to become very important, because we want to make sure that the wound is healing properly. 1, based on how you take care of the wound, and 2, that you're not putting too much pressure on the wound. So, you know, your doctor should kind of go through with you how you get up after a C-section, how you hold on to the wound to make sure there's no excess pressure there to prevent it from opening up or leaking. And also to optimize your pain control, because a lot of times what happens is that because you're in so much discomfort or you're in so much pain, it's difficult for you to do the normal mobilization that you would do. And in addition to all of this discomfort, you also have a baby that you are carrying or taking care of, you know. So things like, you know, when is it okay for you to go up and down the stairs? When is it, you know, okay for you to start driving again? When is it okay for you to resume all of your normal activity? So that is something to go through. In terms of just general hygiene, I mean, these are things that I have learned along the way as well. You know, patients saying, "Doc, you know, with this C-section thing, I cannot even tidy myself down there properly, because every time you bend over to do something, it's pain." And you know, they have like the different bottles that you can use to squirt and all of these.
Very much.
Right, wonderful thing, right? You have patients who were previously very, very active. So patients that, you know, were, you know, big on exercise, gym, all of these things that, you know, suddenly they weren't able to do it for 9 months, and we'll be looking forward to getting back to that routine. But, you know, the follow-up should be along the way, and then routinely review you again at 6 weeks to make sure that the healing that has taken place should be enough for you to resume most, if not all, of your normal activities, including exercise. Now, exercise doesn't mean that you're going to necessarily go back immediately to what you were doing before, you know, but it's a gradual thing to get back into. So I think that, you know, it's just important to discuss that part with the doctor as well, and to try as best as possible to have as much support as you can get at home from your partner, your family members, etc., to help with that recovery process.
Yeah, definitely agree. I think there's not much more to say about that. You know, you said it all. It's the mental preparation for the patient is very important.
Yeah.
You know, so you have to, and the support is important, always important, physical, emotional, psychological support, you know, for that baby, for that wound healing, all of those factors that you mentioned.
But you see, as you just to put in as well, Daryl, as you just said about that, the mental preparation. Why that is important is because, especially for patients who have never, you know, gone through a C-section before, what you may have in your mind in terms of what to expect afterwards may be totally different, and then your recovery process or healing process, as well as your ability to bond well with your baby, is then affected. Because, you know, you may think of it as, oh, C-section, easy, boom, baby's out, I'm fine. And boy, but, you know, nobody told me about this pain. Nobody told me that I wouldn't be able to move. Nobody told me that this is what, you know, this is how it would be. And so, you know, mentally you're affected by that as well. So that is important to go through in terms of what really to expect, so you can prepare your mind for that.
You know what I normally do as well? Depending on the relationship I have with the patient, I'll call another patient right then and there with the patient who had a previous C-section or had a recent C-section. I said, let's go. I put her on the spot. I said, Miss X, I have Miss Y here. I'm putting you on the spot right now. She wants to ask you a few questions about the pain, about the recovery. You willing to answer? And they just, at the end of the day, they're exchanging numbers and contact information, and
Going through it.
so
Well,
going through
I
it. So
mean,
it's good. It's good to
yeah,
hear
no,
from
it
another
is.
party.
A big
And
part
the
of
thing is
it.
that I ended up with an emergency C-section. So having gone, I think having gone through that and explaining that whole process to my patients, they also be like, oh, you know, okay. Because I'm like, listen, I went into this was supposed to be my last doctor's visit. I was already starting to feel pain. So I'm like, I can do this. I'm a G. I'm going to do this vaginal delivery thing. You know, all these doctors said, no, man, why not just request a section? I said, no, I'm going to push my baby out. Yeah, she had another thought coming. So I ended up in an emergency. And I'm like, wow, okay. All right. So this is what the patient feel like. All right. You know, and then
Jody, how was it for you, like being on the patient side? Like, is there anything that you would say, boy, I feel like something that you learned that you would say, you know, I should probably start telling my patients this, because I never even thought about it. I did it. You know what I mean?
Yeah.
It was surreal to me, because it's like you're on the other side of the table now. So it's like I'm like, I can walk in. They're like, no, we have to go on the stretcher. I'm like, I can walk, you know. I'm like,
Yeah.
you know, I was really a bad patient, trust me. But I think I found that my anesthetist could have been a little more. I guess she just assumed you're a doctor, so you know what's gonna happen. So she wasn't too she wasn't trying to be like, no, it's okay, and prepare me. Even though I was like, I don't think I need a section. Like we're not going to do all kind of tests, no. Trust me, I was questioning everything. But,
so how did it feel when you heard knife to skin and they started off?
Exactly.
Yeah, no,
how did it?
No, listen. It was, I'm telling you, it was surreal. From the spinal, like feeling that feeling when the anesthesia is going in. I'm like, wow, okay, this is what this
The
feels
warm
like.
feeling.
Yeah, that little warm. Then you hear them say you feel warm and it feel like pins and needles, like you fell asleep on one of your legs. That's how it feels when the anesthesia is starting to work, and all you're feeling is like movement. And nice to skin, you're like, okay, I'm not feeling that. That's good. That means the anesthetic working. And then they're pulling and tugging and they start to push. And I'm like, okay. All right.
I'm so glad you can share this story, Jody.
Yeah.
This is a very important.
It's much better when you can relate.
Yeah, man.
You know?
I'm so glad you can share
believe me. Let me tell you something. Having been pregnant and I had certain prem labor, I had to monitor my blood pressure for like a week or so. I think I was just a little anxious and probably too busy trying to finish up work. But you know, everything was like I had ligamentous pain, I had degenerating fiber, I had like every complication that I could think of, you know, like other than GDM, thank God. But like when I went in and I said, okay, I'm going to push in the doc, and she's like, all right, let's do the examination. And the baby heartbeat started to like slow down, and I was like, that doesn't sound right.
Big
you
B
sure
cell.
that's not my heartbeat? You sure? And then it goes back up, and I was like, all right, okay. So this is gonna happen today, like right now. All right.
Yeah.
You know, but being on that side of the table and hearing them talking, and of course I'm asking them because it's like, so what's going on? What's in the scene down there? You want to do like a tummy tuck, But I think we don't really understand how the patient, because it's like the patient just feeling all kind of movements, she's just feeling like stretching, and you're moving, your tummy is moving one way, and you're like, okay, what are they doing like right now? But I know what they're doing, but it's like, I'm not feeling like the patient. And they're like, okay, so this is what they're doing.
Why I asked is because, I guess Daryl as a guy can relate to this, when you're going through the different steps in the C-section and you're talking to mommy, all right, mommy, just a little bit of pulling now, a little bit of pressure. You have no idea what that feels like.
No, yeah, trust me, it feels
what that feels like,
weird.
Yeah,
it feels really weird.
Yeah.
But
how was your recovery? How was your recovery?
Listen, I ended up with spinal headache. I tell you, I had spinal headache. But I was mobile. I think I was mobile. Like by the next morning, I had my section like 5:30 in the afternoon. By the morning, I had gotten out of bed. I tried to walk to the bathroom. And I don't think I got more. I didn't take one of the pain medications because I was trying to say, But I can tell you, yeah. You say about 12, like probably 16 hours post. Yeah, man, you get a nice little pain there that you can't move.
Ignore it.
Your tears come into your eyes, and you're like, what on earth is going on here? So you're like, all right, nurse, I think I need that thing.
Bring it.
Yeah, just bring it. But I think I wasn't really prepared mentally, because I tell you, I was not going to do a section. And I don't think we had discussed it, because in my brain I was like, I guess my doctor also thought, she's an obstetrician, she must know what to expect, so sure.
And stick up in, most doctors get C-sections, guys.
Yes. Yes. On doctor's wives.
Yes.
Yes.
Doctors' wives, I think we're cautious. They always end up with a C-section, whether emergency or urgent.
One reason or the other.
One reason or the other. So that's a big point.
Trust me, that recovery process was definitely, it was rough, especially the first week, because like when that uterus is contracting to go back to normal, Kevin, I wish you could say we could relate. I mean, but I made sure to take the medications as directed after that. After I was trying to tug it out, I was like, no, let's just do this thing like how it's supposed to be. And I think probably after 2 weeks.
I guess that's why it's good to, like, when you're reviewing your patients and you see them like the first week after section, you have to find out, how are you coping with the pain. Some of them saying, doc, I don't really feel any pain anymore. I stopped taking pain medication.
After a week.
Some of them will say, boy, that the pain still thing, and you need to give them more pain medication to ensure that they're comfortable,
Kevin, some women deal with pain differently,
Everybody
I have had patients, I think, this girl right now, I delivered her, and I delivered her 8 o'clock in the morning, and she opened Andrew's door for me. She said she's ready to go home. It was the quickest bounce back I've ever. 12 hours, no pain. Doc, I'm ready to go home now. I don't want to stay here no more.
Wow.
That one patient blew my mind. I think
ready
I
to go
her home like the next night, if I'm not mistaken.
I was home. I was up and walking, but I tell you, I never skipped the Voltaren PR.
Okay.
Every patient that tell me that them don't want it, I I took nothing else. I never took any meds, nothing. That Voltaren.
Good to go.
Yeah, good to go. I was up, and when they took the baby to bathe her the next morning, I'm walking. I hear her crying outside. I'm walking down. They're like, Doc, where are you going? I said, I hear her crying. I don't know what to do to her out here. I'm going to walk to see what's going to do. I don't know. So they're like, okay. But I was out like the next morning.
That's good.
24, like 36 hours cup. But that spinal headache came like 3 days later. So when I feel like everything was all right, I guess maybe